Hello and welcome. My name is Jameka McElroy. I'm Vice President of the Board of Directors for the SDPA, and I am joined by Emmanual Agnant and Takeia Horton. And today we'll be talking about managing psoriasis in skin of color population. So I'll let you go ahead and introduce yourselves.
I'm Emmanual Agnant, Derm PA and co-chair of the IDEA committee.
I'm Takeia Horton. I am a Derm PA and co-chair of the IDEA committee. We are happy to be here.
Awesome. So I wanted to start off by asking you all, when you're treating patients in your clinic who have psoriasis and have darker skin tones, when it comes to making that diagnosis, why do you all think it is so difficult sometimes?
I think a lot of times it's difficult because we are taught in medical training to look for that bright red erythema and silver scale. That is not what psoriasis presents like on skin of color. We all know it's going to be more of like a purple violaceous color, a little bit of a plaque, and it's a little bit harder to distinguish if you haven't seen it in office and in practice. And a lot of times we're looking for hyperpigmentation, so darkening of the skin. So I think it's really hard when people see skin of color, they're looking for that bright red. And they're like, well, that's not red, that's not really a silver plaque. Well, you have to take into consideration the patient's skin tone and how that may change the presentation of what you see.
What are some diagnostic tips that you could give someone who's new in practice, or what are some things that you like to do when you're trying to diagnose psoriasis in patients with darker skin tones?
And in addition to what my colleague says, there's also deficiencies in medical training and also education. What we say is that a lot of textbook doesn't have pictures of people of skin of color.
Yeah.
If you look at the databases, unlike the textbook, so you don't see so many patients of skin of color. So sometimes it's very hard for the clinician that not used to people of skin of color to diagnose this condition. And there's a study done in 2018 that actually mentioned in clinical textbook, it's about 4 to 5% of patients of skin of color that they have their clinical photos. So because of that deficiencies, it's hard for clinicians to diagnose psoriasis in patients of skin of color.
I usually tell my people to look for that purple discoloration, gray discoloration, hyperpigmentation. I love Visual DX and trying to find all the skin of color textbooks I can. And just, if you're not sure, biopsy.
Yep.
If you're never sure, biopsy, biopsy, biopsy. That will give you a better understanding of what's going on with the skin.
Are there any labs that you like to order in addition to doing the biopsy that is helpful in this particular patient population?
For biopsies, yes, we can get that straight diagnosis, but also if you feel like it could be tinea corporis, you can have like maybe do like a scale culture of the scale, so that can help you come up with a good diagnosis. And because of that presentation that we usually see in patients of skin of color that's different than Caucasian population, sometimes psoriasis can be misdiagnosed for discoid lupus because of the discoid shape. And also too, we can see sometimes that violaceous looking can also, they might think is lichen planus or something like that because of that presentation. And that's why it's very, very important to do various, lab or biopsy to get the diagnosis.
And also ask those leading questions, joint pain, nail pitting, heel pain, all those things, the PEST questionnaires. Like, you want to investigate a little bit further. Are they having other autoimmune issues? Are you having fatigue, hair loss? And so that may lead you down a pathway of more labs of looking to an autoimmune disorder, but it's more of that investigative thing that we do as Derm PAs.
And that's very important because joint pain, sometimes we tend to forget about that. Patient can have little psoriasis, maybe on the scalp, and we might think it's seborrheic dermatitis, but when you ask more leading questions like joint pain, so we realize that it could be psoriatic arthritis. So it's very important to do a thorough examination of this patient, especially in people with skin of color.
So Derm PAs, we're supposed to be detectives, so we need to really ask the questions, look for the clues that's going to help us get to the diagnosis. And I really like the fact that you pointed out that we should have other differential diagnoses that we're thinking about, using our bedside tools, like doing our KOH prep and skin scraping to differentiate psoriasis plaques from like a tinea corporis. And Takeia, you talking about making sure to ask about those other questions, nail pitting, joint pain, fatigue. Those are other signs that can be associated with psoriasis, even if there's not a lot of skin involvement.
Exactly.
What are some issues with delayed diagnosis? What do we find is a sequela or a burden to the patient when we delay the diagnosis for psoriasis?
Yeah, so even though psoriasis is more common in white populations, people with skin of color are diagnosed later and at a more severe disease where they've already developed psoriatic arthritis. And we all know that psoriatic arthritis is debilitating, life-changing. And when you think about it, if somebody have caught this disease 10 or 15 years before, this patient may be able to continue working, and it really impacts their quality of life. So with skin of color, when it gets a delayed diagnosis, you then lead to more disability and debilitating disease from the psoriatic arthritis, and also just impact on their quality of life, their skin disease, how that interact with their colleagues, their coworkers, their friends, their families, their personal relationships. Think about the detriment that may have had on them and how much we could have improved that if it was diagnosed earlier.
And also there's that implicit bias, like for example, a physician that not used to, well, lack of experience, doesn't know how to diagnose psoriasis on a skin of color patient might default to a more common diagnosis. And then, so because of that, there's a delay in diagnose these patients. Also, we found that patient awareness, like for example, a patient might have psoriasis, but doesn't think that this is something that's so serious. It's a disease that, not only on the skin, but there's a systemic involvement. Just think that, okay, that's a dry skin, so I'm gonna stay with that. So they don't seek treatment.
And I think part of our jobs as PAs in general, not just derm PAs, is to recognize this is a systemic disease, so you need to connect them with rheumatology for their psoriatic arthritis. They need to be seeing their primary care to make sure they don't have cardiometabolic disease. What are their lipid levels? A1C. We may not be running that, but we need to explain to the patient, hey, we need to get you connected to care and make sure we're checking all of that. And what's really interesting in that delayed diagnosis, there's also a delay in treatment because research shows that African Americans and people with skin of color are less likely to be prescribed a biologic, which we all know is the standard care of treatment for psoriasis and psoriatic arthritis. So we need to be thinking that first thing in mind when a patient comes in with rash and joint pain. Psoriasis systematically is on your differential, check for psoriatic arthritis, and they need to be offered the standard care of treatment, which is a biologic.
And maybe you probably experienced that in your practice, but there's patients that have a lack of trust for the healthcare system, especially in African population. I remember I had a patient recently. She had like very severe AD, and we was thinking about giving her some medication to help her, an injection. But she was like, no, I'm not going to take that.
Yeah, atopic dermatitis.
Yes, atopic dermatitis, yes. She was saying, I'm not going to take that. And when I come to realize, it's because she felt like this medication is for white people. But now she saw a commercial and they put people skin of color taking that medication. She came back and asked for the medication now.
So you're also speaking to the importance of how we market these medications to patients and making sure they see themselves and they feel included and they know that these medications work for them. And to your point, that is our responsibility. It's our responsibility to share with them the data in a way that they can digest it and understand it, the safety profile in a transparent way, and letting them know these medications may have some potential side effects, but the benefits definitely outweigh the risk in a lot of these instances. And we are now have the opportunity to give our patients medications that are very safe and very effective long-term. You touched on it a little bit, Emmanuel, but what are some other like socioeconomic and systemic barriers that you feel patients in this patient population face with getting the correct treatment and diagnosis in a timely manner?
We can mention, for example, the lack of resources for these patients. Even sometimes insurance can be a barrier when it comes to seeking for good cares. But some patients, they even looking for people of skin of color to treat them. And depending on the area where they live, they might not get that option. So there's multiple factors that can, in a socioeconomic situation, make patient delayed to get treatment or care.
And I think it's really important for us to advocate for our patients. So if we can't get a medication covered, can we go through a patient assistance program? Like, what do we need to do? If we know our patient needs a biologic for psoriasis, it is up to us to make it work. To work, do we need to call and do a peer-to-peer, call the insurance company? Really find the ways and avenues that we can get our patients on the appropriate treatment, because we don't want that debilitating psoriatic arthritis, and we don't want the patients to continue to have a misdiagnosis or be undertreated and not treated appropriately. And you talked about the research and you seeing people in marketing, but it's also really important to get our communities involved in research as well, because what I hear a lot from patients was, well, how many patients of skin of color were in those research trials? Mm-hmm. And we know that the number of skin of color patients is low, but it's also our point to educate our patients. Well, if you're interested, there are clinical trials that are always going on for different diseases, and explain to them how they work and why it's important for them to get involved.
And that education, not only for our patient, which I completely agree with you, but also with the companies to get even educate them how it's important for them to get people of skin of color doing their studies, the clinical studies. It's very important to do that, because many studies you always see that African American is underrepresented, and they get diseases like other race as well too. So we making sure that they can get their face into the trials.
So we want to speak to maybe some of the implicit bias that we all have as clinicians and providers, and sometimes it can feel like a bit of a taboo topic to think about how some of the perceptions that we have about certain patient populations can affect the care that we give. What is your experience with implicit bias? What are your thoughts on how we can identify it so that we can do a better job as clinicians?
That trust that we want to create, build that trust with patient when it comes to healthcare. I think that's one of the implicit bias that me personally, I'm trying to bridge that gap where a patient doesn't trust a healthcare provider. So we want to making sure from the first visit we build that trust with patient.
I think for me, I hate the word non-compliance. So my question is always, I see you haven't taken this medicine. Explain to me why. What questions do you have? What are some of your concerns? I think in healthcare, sometimes we're trying to be so quick and we're just like, oh, the patient's not using the medication. One, they may not understand how to use it. They may have questions about it. It may have caused side effects and they didn't tell you about it. And so they just stopped using it. So it's more of being inquisitive, asking questions. Don't make any assumptions. And also a little bit of cultural competence comes into that, especially when you're talking about scalp psoriasis and skin of color. I've had people ask like, well, they just won't wash their hair every day. Well, if you are a person with skin of color, you can't wash your hair every single day. You won't have any hair left. So it's just being a good human, listening, being open, asking open-ended questions, not coming in with any assumptions. And then also, like you said, really recognizing when you have that bias, take a step back, think about it, and apologize and keep going.
Yeah, definitely. And I don't know if you encounter that too. One thing, if you make that decision with the patient involvement, and they seems to be more receptive to the treatment, it's just shared making decision. You don't want to just say, hey, you're gonna take this, and this is the only thing I have for you. But when they share that decision making, it's better.
That's lovely. So the takeaway is to really be involved in the decision-making, shared decision-making with your patient, ask the right questions. And this was a really great conversation, and I think it's a conversation that we need to continue to have about this specific patient population. So thank you both for joining me.